I'd like to introduce Lucy, who's the academic researcher who's led these projects, and we look forward very much to your contribution today. Thank you, Lucy. Very nice to meet you. I'll go and sit where you are, actually, so it's closer. Yeah.
It's very great to meet Ines. I've had emails from her over time saying, what about this point here? Can you just clarify that? So it's great to meet you in person. Tēnā koutou katoa. I'm very excited to be here this morning and to be the opening session. I read something recently that said that if you reframe nerves as excitement, then it's much easier to speak, so I'm feeling very excited. When I presented the first Respiratory Impact Report at the 2014 conference, I gave a lot of detail. Oh, I've got to find my clicker now. Here we go. Does this work? That one. There we go. Far too much detail for anyone to take in, possibly useful if you had a particular interest and waited for that set of slides to flash past. But today I want to give more of an overview. If you are one of those people with a very particular area of interest, then the detail is there in the 2016 report. And so if there's anything where you want more information, including the technical methodology or anything like that, then the report is the place to look for that. The report covers total respiratory disease and 5 indicator conditions that the Asthma and Respiratory Foundation identified as being good signs of where respiratory disease was headed in New Zealand. Those conditions are asthma, bronchiectasis, childhood bronchiolitis and pneumonia, and adult COPD. It also covers the cost of respiratory disease and has a brief reference to some other related issues like smoking. You can find rates over time by ethnicity, by socioeconomic deprivation, and by region. I'm looking forward to updating all that detail again next year. It sounds sad, but I really am. I'll be providing some of the basic statistics this morning, but I really want to focus on the patterns. What does the report tell us about New Zealand's respiratory health? As a clue to where that's going, the report notes in the early pages that by far the most relentless and disturbing pattern in the statistics was the high degree of inequality across both the socioeconomic spectrum and different ethnic groups. These patterns are important on their own, but they also provide the backdrop to what I hope other speakers will present today and tomorrow. When I presented some of the respiratory data, inequality data, to a group of medical students, their response was more or less that they already knew everything was terrible and they wanted to know what to do about it. And I'm glad to see so many options over the course of this conference to hear what is being done about it. I'm going to start with the driest of the figures, which are the costs of respiratory disease. Now, cost estimates lag behind in time because they include the cost of lost lives, and we don't know who's died of what until 2 years afterwards. So these costs are from 2013. When we include all the costs we can calculate, respiratory disease comes to over $6.2 billion. $858 million of that is from asthma, and the rest is from other respiratory disease. About $535 million of the total cost is dollars spent by the health system on doctor's visits, prescriptions, emergency and outpatient visits, and hospitalizations. The rest comes from how we value the year, a year of life, or a day off work, or a year lost to disability. As a clue to what's coming, I would expect these costs to come down in the next report because the cost of mortality makes up such a large part of them. And as you'll see in the next slide, respiratory mortality rates have been decreasing. So here we can see the mortality and hospitalisation rates over the study period, which was from 2000 to 2013 for mortality and up to 2015 for hospitalisation. So to contradict those medical students, I'd say it's not all bad news, it's just mostly bad news. Overall, total respiratory trends are contradictory. Hospitalisation rates are going up, mortality is coming down. And there is a fairly obvious reason why those two lines head in different directions, and that's because of who's dying compared to who's going to hospital. Most mortality, that's the red in here, is in older adults, and older adults have been living longer than in the past. With hospitalisation, so there's a solid proportion of them that are in the very young as well. They tend to survive, fortunately, mostly, to come back to hospital again. And the older adults are staying alive to go to hospital more too. So that means less deaths, even as hospitalisation rates increase. And that's important when we think about where to focus our efforts on reducing respiratory disease. So back to the trends. This is the good news in the report. What we see in total respiratory disease, increased hospitalisations but lower mortality, isn't necessarily what's happening across other indicator conditions. In asthma, mortality and hospitalisation rates have both come down since 2000, and they look like they're staying down. Part of my excitement about repeating the review each couple of years is that I get to see have these trends continued. Is this carrying on? And it was really great to see that what looked like a trend in 2012 of things coming down has stuck and stayed down. Not all asthma trends are as clear. The proportion of children who are currently taking medication for asthma has snuck up from a low of 14% in 2012 to 16% in 2016, and that's 18% for boys and 15% of girls. That's a lot of children taking asthma medication. Overall, these changes aren't yet significant, and they could be good news if the proportion of children with asthma hasn't changed, but the rates of hospitalisation are going down. That suggests that we're getting better at managing it. So you can take something good from that. COPD, I'd say, is also more good news than bad. The hospitalisation rates haven't really changed, but the mortality rates are coming down. There are about 40 less deaths each year from per 100,000 people than there were 10 years ago. That's for the age group over 45. And that's about where the good news stops. Bronchiectasis is up, both for hospitalisation and mortality. The mortality levels might be levelling out, but the hospitalisations are not. There is a chance that some of this is about increased diagnosis of bronchiectasis, and I'm hoping other people in the conference can talk about that. And I also hope to hear further work looking at that question, because I really hope that's about diagnosis and not just that things are getting worse. Bronchiolitis hospitalisation rates also continue to climb. On the plus side, there were fewer deaths in the second half of the data than in the first. These are just total numbers of deaths for children under 5 years. Numbers are too small to show a definite trend, so you're in the range of no deaths in some years and up to 3 deaths in other years. And last, there's the childhood pneumonia. Now, when I presented this at the 2014 conference, I had high hopes for pneumonia. If you look at what that line's doing when you get to 2013, it looks like it's not on a nice trend downwards. Unfortunately, that turned out to be false optimism, and the numbers have gone back up again. And I'm finishing these kind of general trends slides with this one because I think it's easy for numbers to blur into each other. And sometimes when you get down to the small numbers, it's easier for them to feel real. So the top graph here are the deaths from childhood pneumonia, and I've included the 2014 deaths, just slipped them in before I came to the conference, because one of those 6 deaths there was Emilita Bourne, who died of complications of bronchopneumonia in a house with a leaking roof, which her family couldn't afford to heat. And that's probably a good lead-in for the next set of slides, where I'll be looking at where we are now. And where we are now depends very much on your ethnicity and on your wealth. This chart gives you the general story. Respiratory disease hospitalisation rates are higher if you're Māori or Pacific, so the two sets of bars on the left. And they're also higher if you're in an area with high socioeconomic deprivation. So that's the gradient from dark green to light green. These risks are compounded. So if you're of Pacific ethnicity and in the least wealthy quintile, least wealthy 20% of Pacific people, your respiratory disease rates are nearly 5 times higher than if you're New Zealand European in the wealthiest areas. Across the indicator conditions, whether it's asthma, COPD, chronic bronchiolitis, or childhood pneumonia, the numbers change a little, but the story stays pretty much the same. Pacific peoples don't necessarily have the same socioeconomic gradient as other groups. They might just be bad across the socioeconomic spectrum. And Māori have higher levels of COPD than Pacific do, but otherwise it's generally the case Pacific respiratory health is worse, followed by Māori, and there is a strong gradient by socioeconomic status. And we have had this for years. This is not new, it's just still there. The same is generally true for mortality as well, so I haven't given you another set of graphs because they look pretty much the same. Instead, for mortality, I'm going to focus on the small numbers again and come back to bronchiolitis, where perhaps because the numbers are small, the differences seem most stark. We had 9 deaths between 2000 and 2004 and 2013. 4 were Māori, 5 were Pacific children, and only 1 child was New Zealand European or other. 7 of the deaths were in that least wealthy quintile. None were in the 2 wealthiest quintiles. People may debate whether or not money can make you happy, but it does look like money means that your children don't die of bronchiolitis. I'm aware I haven't really covered much about age in this presentation, and that's because age pretty much goes as you'd expect. The elderly and the young have more respiratory disease. Instead, I'm going to just give you a brief showing of what respiratory illness is doing by region. These are our 21 DHBs, and I've just shown them there so you can see that from the top to the bottom, from north to south, there's a very rough gradient. So ideally, we'd all be living in Nelson. If anyone's looking of where they want to retire, we've got some people from Nelson, excellent. And then finally, I wanted to go on to 2 risk factors relevant to respiratory health. First is tobacco use. Tobacco companies have been more successful in getting and maintaining their market among Māori than among other ethnic groups, which will be contributing to the higher rates of respiratory disease for Māori. So efforts to reduce tobacco use remain an important target for reducing respiratory disease overall and for reducing inequalities in respiratory disease. And we do track those tobacco use rates in the Respiratory Impact Report because it's an important contributor. And then last, because I work in housing and health as well as respiratory reporting, and poor housing is a risk factor for respiratory disease, the other risk factor I want to mention is housing. This isn't covered in the respiratory report, but I know Philippa will be talking about research in housing and health shortly. So I wanted to highlight the importance of that by illustrating some differences in housing quality by ethnic group, in particular because they show the same pattern as we see in respiratory health. The differences here are not huge in terms of scale. There are only a few percentage points, so the quality of housing for Māori and Pacific people is worse than the quality of housing lived in by Asian and New Zealand, European and other people. But this is from a data set with very little variability, so that small difference is meaningful at a population level, and all those differences are statistically significant. So to conclude, there's a little bit of good news, mostly in asthma and mortality rates, but there's also a whole lot more work to do. If we want to bring respiratory disease rates down and reduce health inequalities, or even just to be able to spend our health dollars on other things, and if we're here, then clearly you're interested in that, then we need to focus not only on better treatment, which feels a bit unfair to say if the session's being sponsored by AstraZeneca, but also on reducing the problems that cause those high rates and inequalities. Here I'd highlight the ongoing efforts to reduce smoking and to improve housing, and also to improve the health of children. And that seems like a good time to pass over to my esteemed professor, Philippa Houghton-Chapman.